This is lesson 36 on institutional and nuclear pharmacies. We're going to be covering pages 213 through 225 in your book. Once again, it's going to be a little bit of a longer lesson, but I didn't want to divide up the institutional practice material into more than one lesson. So stick with me, we'll get through this, and actually we'll be done with this chapter by the time we finish this particular lesson. Okay, on page 213, we're talking about institutional pharmacies. And on 5A, I call this rules applicable to all institutional pharmacies. And the first one is that all institutional pharmacies must have a consultant pharmacist of record. We've talked about who the consultant pharmacists are, and each institutional pharmacy has to have a consultant pharmacist of record. And remember, this includes both hospitals as well as nursing homes, as well as any of these modified Class 2B institutional smaller types of facilities. They all must have a consultant pharmacist of record. The board has got to be notified of a change of a pharmacist, a consultant pharmacist of record within 10 days, similar to the prescription department manager. Remember, the consultant pharmacist must do drug regimen review and inspect the facilities at least once a month at all these types of institutional pharmacies. Now, obviously, a hospital has got a full-time pharmacist that would not apply. That's being done all the time. But really, for a nursing home or other type of facility, they do have to make an on-site visit at least once a month. Okay, so the next rule on page 214, even though I got this under the section for rules that apply to all institutional pharmacies, this one is actually specific to nursing homes. So this is the labeling again. Remember I told you the boards are real big on labeling, the MPJE is real big on labeling. So this is labeling of drugs for inpatient of a nursing home. And I put a note there because there is a difference if you're using conventional dispensing, like in bottles, which I don't think anybody really uses in a nursing home. They usually put things in blister packages and they use unit dose. But what it says is if you're doing conventional dispensing, you actually have to include the name and address of the pharmacy, the name of the prescriber, the name of the patient, the date it was filled, the prescription number, just like a regular prescription almost. Directions for use, name of the drug, the quantity, and of course the controlled substance transfer warning. So all those kind of typical things you'd put on a prescription on top of page 214. However, when you're doing unit dose packaging, you can't fit all that information, the patient-specific information, on a unit dose package, right? So unit dose or repackaged products only have to have the name of the drug, the strength, the dosage form, the name of the manufacturer, the expiration date, and then a lot number, either your repackaging lot number, or if it's unit dose from the manufacturer, will have a manufacturer's lot number. So you'll see in the study tip where I try to explain is that when you're using repackage or unit dose in an institutional pharmacy, you don't have to have all the patient-specific information on each individual dose, which kind of makes sense because your unit dose system somewhere in the computer system is going to track which drug is for which patient, prescribed for which patient, and so forth. It kind of makes sense when you think about it, but it's not clear when you actually read the rule. Speaking of the unit dose medication, you'll see on the bottom of page 214 the rules related to pre-packaging or unit dose packaging of drugs. The pharmacist, the consultant pharmacist has to set up the procedures for that. I put in the study tip there because most states, when they talk about pre-packaging, have rules related to what beyond use date can go on these unit dose packages. I could not find a Florida specific rule on what beyond use date can go on unit dose packaging or pre-packaging that's done in a pharmacy. Other than, remember, we talked about the one for customized medication packages. So without a specific rule on this, I would think the general rule that Florida has for beyond use date is not greater than 1 year would also apply to unit dose packaging as well. Any drugs that are stored in a nursing home or institutional pharmacy need to be secured and only accessible to the practitioners that are allowed to administer those drugs. So nurses, physician assistants, respiratory therapists, physical therapists, and radiology technicians, whoever's authorized to actually use those drugs, and all those rules on how you secure the drugs at these facilities have to be set up by the consultant pharmacist. Now, on the top of page 215, you see a rule about returning and actually reusing drugs sometimes in a closed drug delivery system. Because these drugs are not taken by the patient directly, they are administered to the patients in these institutional pharmacies by some healthcare practitioner. It may be possible to reuse drugs that are sent back to a pharmacy. So what it says in this rule on top of page 215 is if you've got a closed drug delivery system that controls unit dose or customized medication packages in any of these types of institutional pharmacies, including a nursing home, class 1, but also hospitals, these modified class 2 hospitals or other types of facilities where they're not handled by the individual patients, they can be sent back to the pharmacy for redispensing if it's clear that the drugs have not been opened or tampered with. Now you'll see in the study tip there, remember the general rule is that once a drug's been dispensed to a patient, it cannot be returned and be redispensed. But there's this exception for these drugs that when they go to a nursing home, remember they're labeled maybe for that particular patient. They've been dispensed, but because they never were in possession of the patient, they're held by the facility, you may be able to take these back and redispense these. Now, DEA does not permit this once drugs have been dispensed, so this is really only for non-controlled substances. Okay, we've got kind of a unique rule here on page, starting on page 215 about transmission of a starter dose prescriptions. This is for patients primarily in nursing homes, which are the class 1 institutional pharmacies, but also any of these modified class 2B institutional facilities, some of these outpatient surgery centers and other types of facilities, maybe some correctional institutions and so forth that we talked about previously. And the purpose of this rule, if you think about it, it kind of makes sense, is the pharmacy that services that particular nursing home or that particular class 2B facility may not be located that close to the facility. They could be quite a distance away, and they deliver prescriptions, to that facility once a week or once every 2 weeks. But a patient might be admitted to one of these facilities and need a medication right away. So this allows the pharmacy that services that facility to contract with another pharmacy located closer to the facility to give a starter dose or a first dose to a patient in that facility once a new order comes in. And the terminology they came up with is the vendor pharmacy is the community pharmacy or a special closed door pharmacy, which actually has the contract to service the patients at a particular nursing home or other facility. They can contract with what's called a starter dose pharmacy, which is one that's probably close by the facility. And then what's created is a starter dose prescription that's transmitted from the vendor pharmacy to the starter dose pharmacy for the purposes of starting the patient on that medication. Now, this cannot be done on the top of page 216 with a controlled substance prescription, but if the conditions are met there on the top of page 216, that they've got authorization from the facility to use this other pharmacy, the prescriber has authorized this as well, you've got a valid prescription from the prescriber before you transmit the starter dose to the other pharmacy, you maintain a record and so forth. If all these conditions are met, and again, this makes sense, it allows, prevents a delay in initiation of therapy for these patients if in a situation where the vendor pharmacy is located a good distance away from the actual facility. Okay, on page 216, we see a labeling rule again. And these are labeling requirements for medications in a class 2, modified class 2 type B or class 3 permit. And these rules, it talks about patient-specific medications, but not plain IV solutions. So this is the typical type of labeling you would see like in a hospital type of practice. Obviously, you have to have the name of the drug. Some of these things only apply if the product's being compounded. You'll see because it talks about the responsible compounding personnel or dispensing pharmacists. That would only apply if the product's being compounded. It also has labeling requirements for batch prepared compounded sterile products. You'll see there on the bottom of page 216. And then obviously, if it's going to go to a patient in a facility, it has to have the patient's name and the location where the patient's at inside the facility. So again, labeling requirements are something you want to know for each type of individual practice in the state. So the next section is about outpatient dispensing. We talked about this already. Remember, institutional pharmacies cannot do outpatient dispensing. There is this exception if they want to give a supply to a patient that came into the emergency department, they can do that. However, it's limited to a 48-hour supply only. If there's a governor declared emergency, they can go up to a 72-hour supply, not much longer. If you're going to dispense drugs for a patient to take home out of the emergency department of a hospital, you need to keep records of that, and the record keeping requirements are listed for you there in letter 2C on page 217. We also got a security rule for institutional pharmacies. Again, this is really for hospital pharmacies, class 2 or class 3. Same thing generally applies when a pharmacist is not available. The prescription department or the pharmacy department is considered closed. And what it says is nobody can go into the pharmacy department. Then it says except as authorized by section 465.0192B and rule 64B 16.28.602. That's what it says. The problem is you got to go back and read what those sections say, and what those sections say I've summarized for you on the study tip on page 218. If you go back and read those sections, it says that when the pharmacy department is closed, a single dose may be obtained under the supervision of a physician or a charge nurse. So what this implies is that in a hospital pharmacy, yes, when a pharmacist is not there, it's considered closed. However, you may authorize either a physician or a charge nurse to go into the pharmacy to take out a single dose, but no other people are allowed to go in. You can't authorize radiological technicians, pharmacy technicians, only a charge nurse or a physician that the pharmacy has approved to go into the pharmacy department. Okay, on page 218, we have an automated distribution and packaging rule for institutional pharmacies. These are the rules related to automation. It covers primarily your Pyxis type machines, as you see in the picture on the slide there, that a lot of hospitals use to allow drugs to be stored throughout the hospital in different patient care units. But it also includes what are called centralized automated systems, which some of these large hospitals might have these robotic systems in the pharmacy that help with dispensing as well. What you'll see here is the consultant pharmacist is responsible for the operation of these machines, and it tells you specifically all the things they're responsible, making sure that they're working, making sure there's a procedure for stocking these systems, compliance with all packaging and labeling requirements, and so forth. And then on letter C on the bottom of page 218, it does say that when you're using these systems, a pharmacist must review an order and prospectively do prospective drug use review and approve a drug order before a nurse or some other healthcare practitioner takes a drug out of one of these machines. Now there are exceptions to that, and that is there's 3 different types of situations where a pharmacist does not have to review an order before a drug is taken out of one of these automated dispensing machines. The first one is called an override medication on the bottom of page 218. And that is a medication where a single dose can be taken out where it's been determined that if we wait for the review by the pharmacist, there could be a significant delay, could compromise the patient's treatment. So probably in an emergency room, you may have a lot of override medications. And then there's a second category, which are called low-risk override medications. And these are just drugs that we're going to designate that even if it's not going to be a delay, it's a low risk that there's going to be any type of drug interaction with these particular drugs. You know, it might be some for like Tylenol or some type of I don't know, other very low-risk medications that can be taken out without having a pharmacist do a drug use review every time you get an order for one of those particular drugs. And then the third category, where you may not need a pharmacist to review the order in advance before the drug is taken out of the machine and approved by the pharmacist, is called physician-controlled medication. That would also cover the emergency rooms because the physician's controlling the administration of the drug, but also probably places like an operating room or recovery room or a place like that where everything's controlled by a physician. Then you may not need a pharmacist to review it. But standard distribution of drugs on a patient care unit in hospital for routine drugs that are going to be given daily would require a prospective drug use review by a pharmacist before the first dose is taken out of these machines. Decentralized machines in letter E on page 219. Decentralized medication systems talks about who can restock them there, and it requires a daily audit unless the system uses a barcode for restocking. Decentralized means it's not in the pharmacy department. So decentralized means it's out on the patient care units. And there's additional requirements that a decentralized machine that has controlled substances, this is letter F on page 219, cannot allow simultaneous access to multiple drugs or multiple strengths of a drug. So really, in the old days, these machines used to have what were called matrix drawers, and whenever a nurse went to access a drug, even if it's been approved by a pharmacist already, the entire drawer would open up and there'd just be like a matrix of drugs, and they could take anything they wanted out of there. You're not allowed to do that if it's for a controlled substance. If it's a controlled substance, only that controlled substance must become available through the drawer system. Letter G talks about those centralized automated systems. These are those robotic systems that are in the pharmacy. You can read the rules for that on letter G on page 219. And regardless if it's a decentralized system or a centralized system within the pharmacy, if you're using automation, you have to have a quality assurance program for your automated pharmacy system. And certain records are required to be kept. If you turn over to page 220, the daily audits that you have to do for restocking these systems, if it's required, remember, if you're using a barcode system for restocking, you don't have to do the daily audits. But if you do have to do daily audits, you have to keep those records for 60 days. And any other type of report's got to be kept for 4 years, as most pharmacy records have to be kept for 4 years. So on page 220, we see the remote medication order processing rule. This is a rule that allows particularly hospitals, but all the institutions that are listed there are allowed to have this. It allows an order when it comes in for a patient to be processed remotely at another facility. So this might come in handy if you have a let's say a hospital pharmacy, and the hospital pharmacy closes at a certain time during the night, but new orders still may come in. It allows that hospital to contract with another hospital, perhaps, to enter those orders into the medication order system at the hospital, or maybe contract with a pharmacist at home to be able to do this, or a service that provides this type of service. When I worked at Cardinal Health, we had a service that we offered to hospital pharmacies where we had pharmacies at a remote location at an office type practice setting, and they could enter orders remotely by remotely accessing their hospital's pharmacy computer system. In order to do this, you can see that the pharmacy at the remote location must have access to all the information necessary to do a prospective drug use review, which is required for any order that comes in, and to approve these orders remotely. These remote pharmacists at these remote locations don't actually dispense the drugs, but they review the orders, make sure there's no problems with any drug interactions or dosages or anything like that, and then they approve the order. And then if you have a Pyxis machine or a decentralized automated pharmacy system, the nurse can see that, oh yeah, this drug's been reviewed and approved by the pharmacist before they take the first dose out of the machine. Any pharmacist who does this, however, must be a Florida licensed pharmacist. So even if it's sent to a remote pharmacist who's in another state, that pharmacist has to be licensed in Florida in order to do this particular type of practice. And because it's Florida, we have to have a policy and procedure with very specific details that I did not put in the book on how this is going to be accomplished. The record keeping required if you're doing remote medication order processing also has to be able to identify exactly who did the remote order processing. So we know in case there's an error, we know who to go back to and try and take disciplinary action against. Okay, the next rule is about emergency medication kits in nursing homes. So emergency medication kits are oftentimes just tackle boxes filled with drugs that a nursing home can use to access drugs in an emergency. And DEA allows even controlled substances to be kept in an emergency medication kit. It's one of the few times where DEA allows a controlled substance to be kept at a location that may not necessarily have a DEA registration. But even DEA recognizes, nursing homes might need access to, let's say, an emergency Valium for patients having a seizure, Valium injection or something like that. So nursing homes are actually required to have an emergency medication kit. Florida law doesn't specify the types of drugs or the quantities of drugs that can be maintained in these emergency medication kits. That can be determined by the consultant pharmacist for the nursing home and the nursing home's medical director or director of nursing. What Florida does require is that the kit itself have listed on the outside of the kit, it has to be attached to the outside kit, an inventory that lists all the drugs that are in the kit and includes on that inventory the earliest expiration date of any drug that's in that kit. So that way we know when we need to go back into the kit and replace any drugs that are expired, because these drugs are not to be used unless there's an emergency. Anytime the seal of one of these emergency medication kits is broken, the kit has to be taken back to the pharmacy and be restocked by the next business day after it's been opened or after it's been used. And like I said, these kits are sometimes actual tackle boxes that you would buy at a sporting goods store, and they've got a plastic lock on it to make sure nobody's opened the kit. But once that plastic lock's been broken off, the kit's got to be rechecked by the pharmacist and restocked by the pharmacist. Okay, on page 221, we see the automation rule for automated systems in nursing homes and hospice and some correctional facilities. So we've already talked about automation in hospital pharmacies with the decentralized and the override medications and so forth. We've talked about automation in the community practice as well. Here are the automation rules for long-term care facilities. What this allows you to do is to put like a Pyxis machine or something like that into a nursing home, and it helps prevent a lot of waste, because normally if a pharmacy is servicing a nursing home, they're sending out a week or 2 week supply of medication to that nursing home. If that patient's medication gets discontinued, you might be able to send it back and redispense that. We talked about that if it's in unit dose, but you may not be able to depending if it's been opened or whatever. So this is a second way of trying to reduce some of the waste in nursing homes by treating it more like a hospital where you can have automated dispensing machines that store drugs that are not labeled for an individual patient. They're filled with like unit dose medications, just like you'd have in a hospital, but they've not been dispensed or labeled or assigned to a particular patient. So again, it's not something you have to do in the nursing home, but it's something you can do if you want to use automation in one of these facilities. And there are rules about how the systems are set up. You have to have policies and procedures, how they're restocked on the top of page 222. Now, if the automated system, this is number 8 on page 222, stores controlled substances, however, you are going to have to get a separate DEA registration for that automated medication system. Now remember, I said if you have an emergency medication kit at a nursing home, DEA does not require a DEA registration. It's one of the few instances where they don't require a DEA registration where drug controlled substances are being stored at a facility. But if you're using an automated medication system, either as an emergency kit or to dispense routine orders of controlled substances, DEA said in that case we are going to require a separate DEA registration. And actually the DEA registration is in the name of the pharmacy that's servicing that facility, but at the address of where the machine is located. Because that inventory of controlled substances is still considered part of the inventory of the pharmacy that's servicing that facility because they haven't been dispensed yet. So all the unit dose controlled substances are still part of the pharmacy's inventory, but they got to take a separate inventory because it's a separate DEA registration for that machine. So just make sure you read this section carefully and understand the difference between an automated system here where a DEA registration may be required versus an emergency medication kit where a DEA registration would not be required. So on page 222, we see an additional rule here that allows nursing homes to institute a formulary system, just like you have a formulary system in hospitals. And it also allows them within this formulary system to do actual therapeutic substitution, where you only have one drug that's on the approved formulary in a certain class of drugs. And this is again in order to save costs. You can substitute therapeutic products, not generic substitution, but actual therapeutic substitution in a nursing home system. There are some rules around this. The prescriber has to authorize the use of the formulary for each patient, for their patient in the nursing home. A prescriber can actually opt out of this formulary system. You also must notify the prescriber before any therapeutic substitution that's going to take effect. And a prescriber also has the right to prohibit therapeutic substitution for their patients. It's a relatively new thing that was put into place I think in late 2020, but it does give some options for both a formulary system and therapeutic substitution in a nursing home type of practice. Okay, one last thing in this lesson, we're going to cover nuclear pharmacies and nuclear pharmacists. I didn't want to create a whole lesson just for nuclear pharmacy and nuclear pharmacy practice, so I decided to add it to this lesson. If you're really unlucky, you'll get a question on nuclear pharmacy. If you're really, really unlucky, you might get 2 questions on nuclear pharmacy. It's just such a specialized practice that you're not bound to see a lot of questions on nuclear pharmacy. So I try to pick out the most important things about nuclear pharmacy practice just in case you get a question on that. So first let's talk about the nuclear pharmacists themselves. There are additional licensure requirements for nuclear pharmacies. They have to have an additional 200 hours of formal didactic and classroom training from an accredited college of pharmacy, and also an additional 500 hours of internship, of radiopharmacy internship in order to qualify to get a nuclear pharmacist license. In addition, a nuclear pharmacist must obtain 24 additional hours of continuing education in order to maintain their license. So it's very, and it has to be about nuclear pharmacy topics, obviously. So very similar to the consultant pharmacist license that has an additional 24 hours of continuing education. So we mentioned this earlier when we were talking about prescriptive authority. Not prescriptive authority, but we were talking about who can take verbal prescriptions and so forth. Only a nuclear pharmacist may receive prescriptions for therapeutic nuclear radiopharmaceuticals, or also blood product procedures. There's some procedures that are done with blood products that have radioactive tagging that they use. So for those types of prescription orders, only a nuclear pharmacist may take those orders. But for diagnostic radiopharmaceuticals, which are the bulk of radiopharmaceuticals that are dispensed in a nuclear pharmacy, pharmacy technicians can actually take those verbal orders. So it's a little bit different than a regular community pharmacy. So you can see the definition of a nuclear pharmacy on page 224. Each location must have a nuclear pharmacy permit. Each one must have a prescription department manager, similar to a community pharmacy. There's restrictions around security and so forth that you can see. The other big thing is the labeling requirements are different, obviously. With radiopharmaceutical products, there's an inner container and an outer container. The inner container actually contains the vial of the radioactive material. That's only labeled pretty much with the radiation symbol and the words caution, radioactive material, and probably the prescription number and name of the radionuclide that's in that particular vial. And then that's got that particular vial is then contained in an outer container, and the outer container has all the more detailed labeling requirements, like the name and address of the pharmacy, the name of the prescriber, the date it's filled, the name of the procedure that it's going to be used in, the amount of radioactivity, and the calibration date and time. That becomes very important in nuclear pharmacy because the calibration date and time is important because you want the product to have a certain amount of radioactivity at the time it's going to be used, at the time of the procedure. So that's kind of equivalent to the dosage, I would say, right? So it's the amount of radioactivity, the calibration date, and the time that it was calibrated, because remember, this is a decaying process, so as time goes on, it's going to have less and less activity. The other kind of different thing with the labeling of these products is you'll see in letter number 8O, it has to have the name of the patient, or it can have physician's use only. So if they don't know who the patient is going to be, but they know they have a patient coming in for a procedure, for a nuclear medicine procedure, and it's a diagnostic radiopharmaceutical, instead of having the name of the patient, it can actually be labeled with physician's use only. That is legal and appropriate for these types of radiopharmaceutical products. And finally, there are some space and equipment requirements in a nuclear pharmacy. I told you we got rid of all the specific requirements about how much counter space we need and how big a pharmacy has to be, and having copies of the floor plans and so forth. The one exception to that is the hot lab area, storage area and compounding area of a nuclear pharmacy still has a very specific requirement in Florida that it has to be a minimum of 150 square feet. Hopefully they don't ask very specific questions like that, but that's the only one I can see that has a very specific space requirement in a pharmacy permit still in Florida. Okay, and with that, we have finished lesson 36, and we have also finished chapter 4. We are almost done with this course. We'll go through the compounding chapter and then some disciplinary stuff, and we will be done with the course.